So we will see what is we will go through two major clinical trials of pembrolizumab monotherapy non-small cell lung cancer in this particular presentation. So the slides are provided by MSD, and I would thank MSD for providing the platform and the opportunity to go through the evidence. Well, this is how we will proceed with discussion. We will start with the landscape of non-small cell lung cancer, how they are. So what is the role of the immune system in advanced and metastatic non-small cell lung cancer? So what is pembrolizumab all about? And what are the clinical trials we have? We have the Keynote 024 and the Keynote 010 trial, which is in the first line and then the subsequent line. So, well, if you look into lung cancer, so you can see the commonest one is the breast cancer. You can see the difference. The blue one is the incidence and the green one is the prevalence. So, if the prevalence is longer than the incidence, that means that the patient is surviving longer. So, just to say that breast cancer is more of a disease where we are able to cure majority of them and they have long-term survival. When compared to other cancers, you can see the green line, the green bar lengthier than the blue one. Whereas if you come down to cancers like lung cancer and stomach cancer, which is the fourth and the fifth, then you can see the green and blue almost are of the similar length. Just to highlight the fact that whoever is getting the cancer are dying very soon. So that's the reason why incidence and prevalence are equivalent. So it would have been always good that the incidence is low and the prevalence is high. That means they're long-term survivors. So just to reiterate the fact that lung cancer is a deadly disease and there is a high translation to mortality with lung cancer. So this is in contrast to breast cancer, where you can pick up the disease early, you can treat them even if it is a hormone receptor positive breast cancer. We have targeted therapy to prolong survival. And even if you go low down, esophagus also is has a similar mortality. Whereas colorectal cancer, we can do surgery, we have targeted therapies to prolong survival. And that's the reason why you see a green line here. So this is about lung cancer. This is basically a immunotherapy era. Immunotherapy has basically come recently. I think we can be optimistic in just predicting that we will have a longer green line in future in lung cancers because of the advent of immunotherapy. As per the latest evidence, what we can recall is nearly 25 to 30% patients with non-small cell lung cancer have a long-term survival. So you can expect even lung cancer to have a longer green line or a greater prevalence when compared to incidence in lung cancer. So this again the similar thing, you can see the difference between the incidence and prevalence, and you can see the conversion to mortality as far as lung cancer, stomach cancer, and esophageal cancer is concerned compared to breast cancer or oral cavity cancer. So the unfortunate thing is we don't have a good screening program for lung cancer, or screening programs have not been that very successful in improving the mortality in lung cancer. So there has been some trials of low dose CT scan to pick up early stage lung cancer. Even though we do it, unfortunately we are able to diagnose only 15% of them in a localized disease or a loco-regional disease. This is completely in contrast to a breast cancer or endometrial cancer or a urinary bladder cancer, where we are able to pick up higher number of patients in an earlier stage. So 85% of them who have lung cancer present with a stage 4 disease or an advanced disease, they will not be able to offer definitive or curative therapy. So this is about the presentation of a lung cancer, and then So initially, if we had to speak of lung cancer around a decade before, all lung cancer patients, we had to just classify them into a non-small cell lung cancer and a small cell lung cancer. If it was a non-small cell lung cancer, the only treatment we had was chemotherapy, and the chemotherapy what we used was a platinum-based doublet chemotherapy. And the survival what we were seeing was in the range of 6 months, 9 months, and even less than a year. So this is what we had, and then we understood that lung cancer is not a single disease. We have non-small cell lung cancer. In that we have histologically different, like squamous and non-squamous adenocarcinoma. After understanding the difference in histology, then we have looked into the genetic level where we looked into the mutations of EGFR, ALK, ROS, MET, BRAF, and many more. So this is one of the classical examples of personalized cancer treatment where we pick up a particular mutation and we target that particular mutation. So you can see roughly around 30% of them will have EGFR mutation, some 4 to 5% will have an ALK mutation in adenocarcinoma. So again, just to reiterate what I said in the previous slide, previously the only treatment we had for lung cancer was chemotherapy and chemotherapy alone. And then we had the era of the targeted therapies where you could identify the mutations present in a particular tumor and you could target them. So now the numbers are in double digits, they're not just single digits now. We have so many targetable mutations present, and that's why next generation sequencing is the way to go, and not just the PCR or the FISH testing. And then we had immune checkpoint inhibitors. So if you had a young lady who was a never smoker, she had a good prognosis, who had a target mutation. What about smokers and elderly people who do not have a target mutation? So in that set of population, PD-L1 has become a very good biomarker, and it is both prognostic and predictive of immunotherapy. So let us see what is the relevance of PD-L1 in immunotherapy in further slides. So what is the rationale of immunotherapy, not just in lung cancer, for any cancer to that matter? Cancer is an immunosuppressive disease. Just the way we have a human immunodeficiency virus where it causes immune suppression by T-cell energy. Similarly, cancer also is an immunosuppressive disease. So there has always been, in normal individual also, there has always been some mutations where some cells develop mutations and they have a tendency to become cancer, but because of the presence of immune surveillance, they are taken care by the T cells and they are lysed. But in the immunosuppression, cancer happens, and cancer is also immunosuppressive by these receptors. What we see is the programmed death ligand 1 and the programmed death receptor, which we see, and then the CTLA4 receptor. So these two are the major ways how cancer basically suppresses immunity by expressing these programmed death ligands and the CTLA4 pathway. So cancer is an immunosuppressive condition. Therefore, if you can improve or enhance the immunity, the cancer can be taken care of. So the way to treat cancer is not just by targeting the cell proliferation. Indirectly, we can treat cancer by enhancing the immunity in the body by what is known as immunotherapy. So by targeting those pathways, the cancer cells cause immunosuppression. If you can target those pathways, especially the PD-1, PD-L1 pathway or the CTLA4 pathway, we can re-edit the edited immune system, and we can cause immune enhancement and immune-induced cancer cell death. So this is again a similar pictorial representation. You can see an inactivated cytotoxic T cell which has a T cell receptor, and we have the major histocompatibility complex there on the tumor cell. So ideally, if the MHC is not expressed or the antigen is not expressed, the T cell recognizes the cancer cell as foreign and it kills it. But if there is expression of these PD-L1 and PD-L2 on the tumor cell, the PD-1 receptor on the T cell is activated and causes inactivation of cytotoxic T cells and causes immune suppression. So if you can prevent the interaction of the programmed ligand 1 and 2 by blocking the PD-1 receptor. So if you can block the PD-1 receptor by a molecule that is pembrolizumab, you can prevent the interaction of the PD-1 receptor with both the PD-L1 and the PD-L2 ligands. So by this, we can prevent the cancer-induced immune suppression, and we can tilt the balance to the other way and enhance the T cell activation and T cell killing of the cancer cells. So this is the national, the NCCN recommendation. If pembrolizumab is approved for first line as monotherapy in both squamous and non-squamous non-small cell lung cancer, provided the PD-L1 expression, the TPS score more or equal to 50%. And they should not have any targetable driver mutations, especially EGFR, AL cross, MET exon 14, RET or BRAF. So in this set of population where we do not find a driver mutation and we have a PD-L1 expression, there is a TPS score more than or equal to 50% in that set of population, pembrolizumab monotherapy is a preferred and is a category 1 recommendation as per the NCCN guidelines. Whereas coming on to the second line setting or subsequent line setting, if there is any PD-L1 expression at least more than or equal to 1%, and they have exhausted the targeted therapies for the specific mutations, or they are negative for targeted mutations, in that set of patients, we can use pembrolizumab in subsequent line, that is in the second line. So we have approval for pembrolizumab monotherapy in first line if the TPS is more than 50%, whereas in subsequent line more than or equal to 1% is required for approval for subsequent line non-small cell lung cancer. So the rationale for assessing PD-L1 expression as biomarker in non-small cell lung cancer is that the upregulation of PD-L1 is a mechanism tumors use to evade immune destruction. Expression of PD-L1 has been reported in many tumor types, including non-small cell lung cancer. In clinical studies assessing PD-L1 expression in squamous and non-squamous non-small cell lung cancer identified patients more likely to respond to pembrolizumab. So, and then the NCCN panel, the guidelines recommend PD-L1 testing as a category 1 testing to evaluate patients for treatment of advanced non-small cell lung cancer. So, for the first time, keynote trials came up with this biomarker of PD-L1 being predictive of outcome from pembrolizumab. So it is always important to have a biomarker in this heterogeneous set of population, because instead of giving this treatment, the majority of them who do not work, in which the immunotherapy may not work, it will be futile exercise and we will be wasting that time and the patient progresses. So it is very important to have some sort of a biomarker. It may not be perfect, but some sort of a biomarker to say that yes, there is a higher chance of response and higher benefit. So there is always a recommendation from multiple guidelines that PD-L1 testing must be done for all patients with non-small cell lung cancer. So we have IHC assays are available to assess the PD-1 expression in non-small cell lung cancer. You can see the PD-L1 IHC, the Pharma DX22C3, and then we also have the Ventana platform SP263. So we have the SP26 and 22C3 platform, the Ventana and the auto-steamer 48 platform. So 22 SP260 is one of the important platforms. So it is always important that I do this TPS scoring or the PDL1 on which platform, because different immunotherapy molecules have different platforms and their approval is different. So hence it is very important to decide on which platform we are doing this PDL1 testing. So SP263 is the platform we use on the Ventana and on the fresh frozen paraffin embedded specimen. So again, to reiterate the same thing, the approval of pembrolizumab monotherapy is there both in the first line and the second line if the TPS or the PDL1 is more than 50% and more than 1% respectively. So first, initially we will discuss regarding what is the evidence we have in the frontline setting in non-small cell lung cancer patients. So this is the famous Keynote 024 study. You can see this is basically a randomized controlled trial of pembrolizumab versus platinum-containing chemotherapy in treatment-naive or previously untreated patients with non-small cell lung cancer whose tumors express PDL1 and whose TPS score is more than equal to 50%. So this is the phase 3 clinical trial, and you can see the inclusion criteria. Untreated stage 4 non-small cell lung cancer, PDL1 TPS should be more than equal to 50%, ECO UPS 0 to 1, no activating EGFR or ALK mutation. And if there is CNS mets, it should be treated. So they excluded untreated CNS metastasis and no autoimmune, which is active, which is requiring systemic therapy. And the randomization was 1:1. The total number of patients was 305. So 200 milligram 3 weekly up to 35 cycles was the pembrolizumab they used versus platinum-based doublet chemotherapy 3 weekly for 4 to 6 cycles, and if it was non-squamous, they allowed pemetrexed maintenance until disease progression. So the stratification factors they used was the performance status score of 0 versus 1, squamous versus non-squamous histology, and Asian versus Eastern Asian versus non-Eastern Asian. The primary endpoint was progression-free survival as per RECIST 1.1. The secondary endpoint was overall survival, response rates, and safety. So one more thing what we can notice, in those patients who progress on platinum-based therapy, crossover to pembrolizumab arm was allowed. Mind you, these patients had more than 50% PD-1 expression, and therefore it was ethical to allow crossover to the pembrolizumab arm. So you can note that crossover has been allowed in this particular trial for those patients who progressed on chemotherapy arm. So these are the results of pembrolizumab versus chemotherapy in terms of the progression-free survival, which was the primary endpoint. So you can see the superior progression-free survival with pembrolizumab 200 milligram 3 weekly versus chemotherapy, and you can see the hazard ratio of 0.50 and the confidence interval being narrow, that is 0.37 to 0.68, a significant value of 0.001. So in those patients who had a PD-L1 or the TPS more than equal to 50%, there was a very impressive hazard ratio of 0.5, and there was 50% reduction in the risk of disease progression or death with pembrolizumab versus chemotherapy. You can just see the median number 10.3 versus 6 months. In the 6 months rate is 62 versus 50%, and you can see the wide separation of curves. So you can see the initial crisscrossing of these curves. So PFS is not the actual endpoint we look into as far as immunotherapy is concerned, but here even the PFS is such impressive because they have used a very potential biomarker of PD-L1 more than 50%. You can see initial separation, so that just says that immunotherapy will take at least at least 3 to 4 weeks time for it to show a progression-free survival difference. So there has been an initial minor crisscross followed by a persistent separation of curves. You can see the last curves just parallel out each other and they don't dip at all. So that just means that uh, so from 100 you can see the fall is up to 70%. So there has been a fall by around 30%, 40%. So after that, whoever has responded, they continue to respond. So that is the basic mechanism how immunotherapy works. It works in a small set of population. If you look into PD-L1 selected patients, you can see nearly 60% of them are responding impressively, and in those who respond, the response is persistent and very durable. So this is the definition of the PFS2. The progression-free survival is basically the time from randomization to objective tumor progression or death. So this is what is PFS. So PFS2 is basically time from randomization to objective tumor progression on next line treatment or death from any cause, whichever occurs first. So PFS1 and PFS2, you can see very important endpoints. Just to reiterate the fact that the efficacy of immunotherapy continues to persist even after stopping, and it is durable even in those patients who have progressed. And you can see the overall survival, which is the lowest most bar. So this is the PFS2. You can see the PFS2 in the Pembrolizumab arm, again 18.3 versus 8.4 months, which is statistically significant. In the hazard ratios, again better, 0.54. And this is the overall survival, which is the secondary endpoint of this particular trial. You can see the hazard ratio is 0.63, and the median overall survival is 30 months versus 14.2 months. The 30-month overall median overall survival without anything, just with immunotherapy. Immunomonotherapy in the first line is very impressive. It is the first time we ever saw such a median survival of 30 months. So this is the updated overall survival for pembrolizumab versus chemotherapy. You can see at 1 year we have 70% versus 54.8% versus 40%. You can see the hazard ratio of 0.63 and 0.49. So very important is crossover was allowed in this particular trial. In spite of crossover, you can see the preserved hazard ratio. And if you could adjust as far as crossover was there, then the hazard ratio was very impressive of 0.49. So effective crossover rate from chemotherapy to anti-PD-L1 therapy was 62.3%. So crossover was allowed. In spite of that, you can see a significant improvement in overall survival. So this just reiterates the fact that using immunomonotherapy at the earliest, especially in the front line in those patients who have a strong PD-L1 expression, adds life. So exposing them as early as possible is very important than reserving these active drugs in subsequent lines. So this again rejustifies the fact that we must do PD-L1 testing for all patients with non-small cell lung cancer. And if we have a strong PD-L1 expression, we must use pembro monotherapy in these patients rather than reserving immunotherapy to subsequent lines. Because just delaying initiating these active agents may shorten the lifespan, and which is what is evident in this trial, where you can see an improvement in overall survival in spite of crossover. There was a staggering 62% crossover in the chemotherapy arm. In spite of that, the overall survival benefit is just persistent. This is again a 3-year overall survival, which is their impressive hazard ratio. And the duration of response. So again, as I described you in the previous slides, that the separation happens a little later, and once the separation happens, the curve just remains parallel to the baseline curve, and these patients just continue to respond, go on and on and on. So you can see the overall response rates are also better, 45% overall response rates versus around 30% response rates, and nearly 15% difference in response rates, which is statistically significant. Median time to response was also better. So this we usually do not see in immunotherapy trials because we don't have such a strong biomarker of the PPS more than 50%. So very rarely we see such strong biomarkers in immunotherapy trials, and we see specifically with pembrolizumab trials. So patients cross over to the on-study pembrolizumab. So 82 patients crossed over from chemotherapy to on-study pembrolizumab. Median treatment duration was 3.9 months. So you can see the median age was 65 years, 57.3% were males, nearly 80% had a non-squamous histology, and these patients had 20% response rates, 23% stable disease, and median time to response was 2 months, and duration of response was nearly 2.1 to 22.9 months. So this is again, none of the trial is complete without quality of life analysis. You can see, and as expected, this is a chemo-free regimen, and time to deterioration was prolonged with pembrolizumab when compared to platinum-based chemotherapy. Median not reached with pembrolizumab versus 5 months with chemotherapy. Time to deterioration of the composite cough, chest pain, and dyspnea as per the URTC QLC30 criteria. So you can see again, quality of life is well preserved if you use immunomonotherapy when compared to chemotherapy as expected. So this is a summary of adverse events. We all know that immunotherapy is very effective, not in everyone. You select subgroup of population, provided you select out, and these are least toxic drugs. So it is toxic in a very small subset, especially they have what is called immune-related adverse events. But if you can pick them early and handle them early, we can prevent grade 3 to 5 adverse events. So median time to treatment with initially assigned therapy, you can see 7.9 months. So there was a longer duration of treatment with pembrolizumab, and chemotherapy was just 3.5 months. And you can see that treatment-related adverse events, grade 3 to 5 was around 48% versus 80%. The serious was 35 versus 31, and led to discontinuation was 21 versus 16, and led to death was 2 versus 3. So this is a reasonably well tolerated regimen. You can see a little bit of comparable serious events is because of a greater duration of exposure than due to the toxicity itself. So this is the treatment-related adverse events. You can see nausea, anemia, fatigue, appetite, diarrhea, neutropenia, vomiting. All these are high with the chemotherapy arm. Constipation, all these, stomatitis, neutropenia. But when you come on to other side effects like pyrexia, pruritus, rash, they are more common with the immunotherapy arm. So immune-related adverse events like hypothyroidism, hyperthyroidism, pneumonitis, skin toxicity, infusion reactions, colitis, thyroiditis, myositis, and all other inflammation of the organs, which is immune-related adverse event, is common with the immunotherapy arm than the chemotherapy arm. So this is the KEYNOTE-024 data of response after completion of 2 years of pembrolizumab, that is after receiving a total of 35 cycles of pembrolizumab. So you can see 31 of 38 patients, 82% had a CR or PR as best response. So 87% patients had duration of response lasting more than 1 year, and 58% had ongoing response at data cutoff. But you can see the impressive durability of response in this particular graph. And we all know that immunotherapy continues to respond even after stopping the drug. So this is a treatment duration and time to response in patients receiving second course treatment. You can see 80% patients remained alive, 50% were continuing on pembro treatment. So the overall summary and conclusion was pembrolizumab is the only anti-PD-1 approved for first-line treatment of metastatic non-small cell lung cancer patients who have a TPS more than 50%. The keynote 024 pembrolizumab continues to show an overall survival benefit as first-line therapy for advanced non-small cell lung cancer if the TPS is more than 50% compared to platinum-based chemotherapy with an impressive hazard ratio of 0.65. The improvement in overall survival with pembrolizumab persisted in spite of crossover in the chemotherapy arm. We had staggering 60% crossover. In the median overall survival for patients who are randomly assigned to pembrolizumab arm is a remarkable 26 months. In the median overall survival for patients assigned to chemotherapy arm was also favorable with historical controls. This was because they were exposed to immunotherapy. The crossover happened in the chemotherapy arm. Superior progression-free survival was also observed. 50% reduction in the risk of disease progression or death with pembrolizumab was seen with a hazard ratio of 0.5. PFS2 was substantially improved in patients of the pembrolizumab arm, and immune-related adverse events with pembrolizumab, most of them were grade 1 or 2, and none of them led to death. So this is about the first-line data, that is the keynote 024 trial of pembrolizumab monotherapy in non-small cell lung cancer. So now we will go on to the second-line therapy, that is the keynote 010 study of pembrolizumab versus docetaxel in previously treated patients with advanced non-small cell lung cancer whose tumors should express PD-L1 at least 1 or more than or equal to 1%. So this is study design. This was a multi-center open-label phase 2/3 trial of patients with previously treated advanced non-small cell lung cancer, and they should have been PD-L1 at least 1% positive, and they were randomized to receive pembrolizumab versus docetaxel. Actually, there should have been a confirmed progression after at least 2 cycles of platinum-based doublet chemotherapy, and if appropriate, a targeted therapy was also allowed. The performance data was 0 to 1, no active brain mets, no active autoimmune disease, and very importantly, there was no receipt of at least 30 gray of thoracic radiation within the last 26 weeks. So nearly 6 months before, they should not have received any thoracic radiation. They had excluded these patients. No ILD or pneumonitis allowed. So the randomization was into 3 arms. There were totally 1,000 patients, 1,000 odd patients. 1:1:1 randomization. So you had 2 mg per kg, 10 mg per kg pembro, 3 weekly. It was continued until progression or unacceptable toxicity, and docetaxel 75 mg per meter square every 3 weekly. So here the primary endpoint was overall survival, because we expect events early, and progression-free survival in the total population, and in patients who had more than TPS 1% and 50%. And secondary outcomes was response rate and duration of response. So this is a study design. In the PD-L1 assessed during screening using clinical trial immunohistochemistry with 22C3 antibody. The initial protocol was archival or new tissue sample. Then amendment was done where they used new sample only unless biopsy was too risky. So they did a rebiopsy at progression. And 456 patients enrolled based on archival samples. So a significant number of patients before the amendment was done, they were enrolled based on the archival sample PD-L1 analysis. The response was assessed every 9 weeks by RECIST 1.1. And for treatment management, immune-related response criteria was followed. And this is the demographic graph. You can see they are fairly well balanced. What you can notice, nearly 80% of them had adenocarcinoma or a non-squamous histology. You can see around 40% of them had PD-L1 more than 50%, and we had the rest 50% had PD-L1 1 to 50%, or 1 to 49%. And this also included EGFR mutant population, very small percentage, 8%. And then ALK mutant was less than 1%. And prior lines of systemic therapy, you can see one line was nearly 70% and more than equal to 2 lines and another 30%. So what we can see is predominant population was adenocarcinoma. They did have half of them more than 50% and half less than 50%, and less than 10% had EGFR mutation, and less than 1% had ALK mutation, and 80% of them had received only one line of platinum-based chemotherapy before. So this is the Kaplan-Meier estimates of progression-free survival in patients with PD-L1 and TPS more than equal to 50%. And you can see the progression-free survival, 5.2, 5.2, 4.1 months. You can see the upper two graphs, whatever dose you use, it doesn't matter. And it is remaining far away, and it is remaining parallel to the chemotherapy graph lower down with a very impressive hazard ratio of 0.59 and 0.56 with a p-value of 0.0001. Again, you can see the progression-free survival if the TPS is more than equal to 1%. Again, here you can see 3.84 versus 4.1 months. So the median maybe the chemotherapy may be a winner if there is a low PD-L1 expression. But if you look into a longer vision, if you visualize the longer follow-up, then you can see a wide separation. Tail of the tail remains parallel to the baseline. So if you look into the median, so immunotherapy is never a winner. But if you have a long-term follow-up, immunotherapy becomes a clear winner. So just to reiterate that, if you have a TPS more than or equal to 1% as a biomarker, here you can see nearly 70% of them may not benefit, or at least 50 to 60% of them may not benefit at all. Chemotherapy and immunotherapy is doing well. Whereas the moment that small 30 to 40% patients who respond, they have a staggering response, and the curves remain parallel. This is the overall survival in TPS more than 50%. You can see the two graphs just lying on each other, and the third, the chemo arm far lower down. Nearly more than 50% improvement in overall survival in the second line. And if it is more than 1%, here also you can see an improvement in overall survival. So overall survival definitely is the endpoint for immunotherapy. You can see 13.4, 10.5, and 8.6 months. Statistically significant overall survival difference between pembrolizumab arm and docetaxel. Basically, the two doses were basically pooled and then compared with the chemotherapy arm. And in the 18 months follow-up, it was clear that pembrolizumab monotherapy was superior to docetaxel in terms of overall survival. This is the overall response rates: 29, 32, 9. Ongoing responses. Duration of response was not reached versus 8.1 months. So this is in 50%, and then in TPS more than 1%, you can see 19, 20, and 10% overall response rates. Then the long-term survival in patients with advanced non-small cell lung cancer in the Keynote 010 study, and in patients who complete 2 years of pembrolizumab. So this is the assessments done, this is the statistical considerations, this is the baseline demographics, and this is the graph of overall survival. 16.9 versus 8.2, almost double the overall survival in those patients who had a TPS more than 50%. And in those who had more than 1%, 8 versus 11.8 months with a hazard ratio of 0.69. So if you have a higher PDL1, yes, there is benefit, but if there is any positive PDL1, and these subset of patients are going to benefit anyways. So this is the same graph where if you stop also, they continue to respond. And this is the adverse events graph where the quality of life is far better with the pembrolizumab arm when compared to the chemotherapy arm. So patients who received 2 mg pembrolizumab had nominally significant improvement from baseline insomnia, appetite loss, and constipation. This is the exposure and treatment adverse events in the overall safety population. You can see the median treatment duration was 3.5 months versus 2 months in the docetaxel arm. And any grade of adverse events was 66 versus 81, and grade 3 to 5 was 16 versus 36%. And again, the similar graph saying that the chemotherapy-induced side effects were more in the chemo arm, whereas the immune-related adverse events like endocrine manifestations were more common in the immunotherapy arm. So the conclusion of the keynote 010 trial was that pembrolizumab was superior to docetaxel in terms of overall survival in patients who were previously treated and you have a PD-L1 expression of more than equal to 1. Higher overall survival associated with higher levels of PD-L1 expression, especially TPS more than equal to 50. There continued to be no difference in outcomes between pembrolizumab doses. Responses to pembrolizumab continued to be durable despite longer exposure. The rate of treatment-related adverse events continued to be lower with pembrolizumab. These data confirm pembrolizumab as standard of care for patients with previously treated PD-L1 expressing NSCLC. Most of the common adverse events in keynote 010 were grade 1 or 2. The most common adverse events for pembrolizumab 2 mg per kg previously occurring in 10% of patients who had decreased appetite, fatigue, and nausea. Most common immune-related adverse events were hypothyroidism, pneumonitis, and hyperthyroidism. So this is a summary. Again, to just wind up, we have two trials, keynote 024 first line and keynote 010 second line. Both pembrolizumab monotherapy. For first line, the TPS should be more than 50% or more than equal to 50%, and for second line, it should be more than equal to 1%. And you can see the response rates, 45% response rates, and here it's around 20% response rates. And then the progression-free survival, significant 10 versus 6, whereas it is 4 versus 4.1. Not that significant if it is just 1%. And then the PFS2 is further significant user in the first line, and the overall survival is staggering different. The hazard ratio of 0.65 and 0.59 in first and subsequent line therapies. So impressive hazard ratio as far as overall survival is concerned with pembrolizumab monotherapy in first line or in second line setting in those who do not have targetable mutations. So this is the product insert and this you can read. So with this, I would conclude my presentation and hand over back to the organizers. And I would thank everyone for patiently listening, and I would thank NSD for providing the opportunity to speak on this wonderful molecule. Thank you.